albumin and draw the fluid out of the third space. What you don't realize is that the capillary endothelium has become leaky, and when you give albumin, it actually goes into the third space and actually promotes more swelling.
Even if the kid is hypoalbuminemic?
If kid is hypoalbuminic, I will try to avoid taking him into the operating room unless it's an urgent operation.
No, post-operatively.
Yes. So even if he's hypoalbuminic, no question of using albumin at all for the first 48 hours. And then we use FFP. FFP actually has extremely good results, as you know. And then that's been our standard management. Yeah.
Okay. Post-op we'll do now because Rajneesh is short of time.
Yeah. Okay. So I will race through this. I know it's one day is not enough for Norwood, but
this is more than I've ever.
Dr. Sharma, I will make sure. I just wanted to tell the audience that all these movie clips, Ashish, all the presentations, there are a couple more presentations here. I'll give them to Dr. Sharma. They're all available. Just you can avail of them. Yeah. And you can write to me. If you have any doubts or anything, I'm available. I would love to see Norwoods being done in the country. So let's. Can you help me open the third presentation, sir? Yeah. Thank you. Actually, that's not the one. You have to open. No, close that. That was not the one. Go to post-operative care of the Norwood. No. Above the middle one, sir. That one. No, sorry, I said the wrong. Close that. It must be that one. Post-op care of hypoplastic left heart syndrome. Yeah. So this will be the last talk on the Norwood, and I can tell you that once you get into the business of doing Norwood, you'll realize that doing a good operation is just half the job done. The rest half of the job is in getting this kid out of the ICU, and it's a tricky thing. I will give you different situations, and you'll realize what I'm saying. Once again, I have no disclosures. Let's talk about single ventricle physiology, just race through it. We know that the circulation is in parallel, and so blood has a choice of going into the lower resistance circuit. That's simple. So systemic, in the single ventricle situation, pulmonary and systemic circulations function in parallel. But if you look at our own circulations, in a normal circulation, our right and left hearts are placed parallelly, but they function in series. The relative proportion of the ventricular output to the two circulations is determined by resistances. So now we come assuming equal mixing, normal cardiac output and full pulmonary venous saturation, which means that you assume that heart is okay, the lungs are okay, then a SATs of 80 to 85% indicates a QP/QS of 1 and hence a balance of flows. But what is important to understand is even at this minimum, this also indicates the minimum volume overload of the single ventricle. It's still operating at what it should ideally do. So this is one actually, Dr. Gaurav, he was asking me about, for a circuit diagram to explain what is a parallel in the systemic circulation and how Glenn offloads. So if you look at this this is a paper by Dr. Earl Austin that was published in 1997. It's got less credit than it deserves. It's an extremely well written paper that explains the physiology. So can I have the pointer here, sir? So in a single ventricle situation, assume that the LV is not working. The RV is pumping blood, this is cardiac output, and then blood has a choice of either going into systemic or pulmonary side. Then this is the amount of oxygen that is taken up, that is, this is the systemic venous saturation, I'm sorry. SVO2, let's see, I've just had this is the amount of total body consumption and of the oxygen, I think CVO2, let me just see what the diagram says quickly. Rate of oxygen supply and uptake in the lungs, I'm sorry. So the P stands for the lungs. So this is the rate of oxygen uptake in the lungs should be equal to the rate of oxygen consumption. That's pretty easy to understand. So what happens is they calculated through a complex mathematical equation. We don't need to know any of this, but I'm just trying to highlight some points through the equation, that the oxygen consumption is a measure of cardiac output, pulmonary venous saturation, and so how does that translate into equations? This is a very important graph. You will see here that a QPQS is along the x-axis, systemic oxygen utilization is along the y-axis. You will notice that actually this is the availability, it is not the consumption, it is what you call as arterial saturation. For any given cardiac output, these are the various cardiac output situations, you will notice that at a QPQS of 1:1 is what is roughly coincides with, so this, at this point, if you actually draw a curve, QPQS of 1:1, and then say you take a cardiac output of, say, maximum cardiac output, systemic oxygen function of pulmonary system. This is one here. This is a low cardiac output situation. This is a cardiac output. So look at this. If you look at this, at a QPQS of 1:1 in a normal cardiac output situation, then your oxygen sats is close to 80. In fact, in the Michigan group, they would say that it's better to maintain the saturations at a lower point around 70s rather than 80s, because that represents a QPQS of 1:1. But see what happens when the QPQS begins to exceed 1:1. As it gets closer to 5, look at your arterial sats is beginning to fall now. That is because less and less blood, more and more blood is entering the pulmonary venous system, the pulmonary bed, and so the blood that's coming back through the tissues has low oxygen. So when it gets mixed up, look at this. This is just an important equation that illustrates a QPQS of 1:1 is what we should be aiming for to achieve an optimum oxygen availability. Now this actually is a better graph. If you look at this here, these are various cardiac output situations, these curves. For a QPQS of 1:1, if you just follow here, this is a low cardiac output situation. This is a better situation here. For a QPQS of 1:1, you are getting your, this is no more the oxygen saturation, this is the venous saturation now. And look at this, when you get a QPQS of 1:1, your the venous saturation, which represents the consumption, is optimal around 45. Say let's take the 700 curve. QPQS with a cardiac output of 700 cc is now having a systemic venous saturation of 45. That is something that is close to a single ventricle situation. But see what happens to the same thing when the QPQS gets into higher numbers. At this point, look at your venous saturation, it's beginning to fall. That is because more blood is now entering the pulmonary system. Although your sats are rising at this point, can I actually just use the board, Dr. Sharma? And because of time, I'm trying to hurry up. I just want to make sure that the group understands this concept very well. It's hard to understand this graph straight away. You can keep this on, just keep the graph on. So let's assume that there is a single heart and a single pumping chamber, and there are two circuits here. One is going towards the systemic side, and the resistance is determined by the SVR. Another is going towards the lungs, and the resistance is determined by the PVR. Now there is a fixed cardiac output. Let's say we have the ability to alter these resistances. If the QPQS is 1:1, which means there is one volume going here and there's one volume going here. So when we plot it on this QPQS here, for a normal cardiac output, if you have a QPQS of 1:1, you will get an ideal mixed venous saturation closer to 45 to 50, which is good for a single ventricle. Most of us, we have a venous saturation closer to 70, 65 to 75. For a single ventricle, 45 to 50 is good. This is at a QPQS of 1:1. If now the QP begins to increase, more blood begins to go on this side, then because the amount of blood that's going into the systemic side reduces, so as this begins to increase, this value will begin to fall. And that is why, if you notice, these have a bell-shaped curves. Look at this. On the other hand, what happens to the arterial saturations? Why it can mislead you? Suppose we start off with QPQS of 1:1, then your arterial sats, as we all say, is closer to 80. This is another curve. Look at the third curve here. So there is a point here. Say, for example, you are getting the sats of 80. As you go higher and higher, paradoxically what happens is your arterial saturation will get better and better. It's looking more and more impressive. So, but don't get fooled, because although your arterial saturation is getting better, look at what's happening to the venous side. So that is why the important, the Dr. Twiddle's group lay stress on monitoring the mixed venous saturations. So if you look at this portion, if you draw a line here and think this is where it is suboptimal oxygen intake, three things can happen, which means that you can identify 3 points. One where both the systemic arterial sats is low and the venous sats are low. So look at this, because this curve is rising. This happens when the QPQS is very low. Say, for example, 0.3. What does that represent? That represents, in a real situation, either a BT shunt that is getting blocked or a sano that is too tight. Does it make sense? So here at this point. So now, if the intensivist will tell you, hey, the oxygen sats are low, 50. Then you will ask him, get a venous sats. He'll call you back and tell you it is 15. Then at this point, you want to know whether you are here on this part of the curve or this part of the curve, because here too your values are low in terms of. So that is why you have to look at all the numbers together. Now you have another situation. So this represents inadequate pulmonary blood flow. We'll talk about it. What happens when you have increased pulmonary blood flow, excessive? That represents a QPQS on this side of the chart. Look what happens here. Your venous sats is still low, which is maybe about 25% or 15%, it doesn't matter. But your arterial sats now, look at this curve, it's probably 90%. So you think, well, patient is having an arterial sats of 90%, you are not monitoring this, he looks great, but the problem is that you are getting into a spiral, downward spiral. Then if you ignore this, or if you don't get a lactate, you will notice your lactate will now begin to rise at this point. It will get into 2.5, 3.5, and if you ignore this, in the next